along in the next few minutes. We won't too much, I guess.
Okay. I'll do a quick introduction. Folks, we've got Dr. Adam Kuhlman, who is the director of the movement disorders and neurology at Beaumont, Royal Oak. I'm going to mute all of you. He's going to be talking about managing Parkinson medications. As I said, I'm going to mute you all now. And then Dr. Kuhlman, you need to unmute yourself, okay?
Okay, so let me just give me 1 second to pull this up here and we'll get started. Again, thanks everybody for joining and tuning in. Let's get this going here. Okay. So the idea of talking to you all today, we're going to just kind of do a brief overview of a number of medications that are available and that can be used.
I can't see you or hear you.
We're having some difficulty with audio. Is audio here? No. Okay. Sorry about that. I was making a comment yesterday. I was having a conversation about giving this talk today, and it's nice that I actually have some new things to talk to you all about. We've had a number of medications that have been released over the past 12 months or so. So there's at least some new content to this lecture when things have been slow going maybe previously. So
hello.
Again, the idea is to.
Hello.
He's got his.
Briefly go over these medications and what things might be used during the course of Parkinson's disease from diagnosis on, and then also kind of go over some kind of special circumstances related to the use of medications in Parkinson's disease as well. So the first thing we need to know about taking medication in Parkinson's disease is that timing is very important, and this applies for most people. Now, I will say that when people are first diagnosed and when we very first start taking medications, sometimes people will tell me that it doesn't make any difference. They can take it an hour early, they can take it 2 hours late, and they have the same even type of symptomatic response regardless of the timing of medication. And that can often be true, especially early in the course of things, right after diagnosis, first couple of years after diagnosis. But the reality is that generally speaking, over time, the timing of medications really makes a big difference, and that being able to take it on time, it will really do pay dividends in terms of even symptomatic benefit during the day. Taking the correct amount, obviously, with any medication is important, and it can especially be true in terms of the way that people experience side effects from some of the medications that we use in Parkinson's disease. And then it requires some monitoring, and this is something that is done by patients themselves and their caregivers, as well as movement disorder neurologists like myself, in being able to try to determine the effectiveness of our therapies.
Ahmed, I can see you, but we can't hear you.
So, I'm sorry. Is anybody else having difficulty hearing me? I keep hearing someone chime in with difficulty.
You can hear you loud and clear here.
Okay. All right. So then I'll keep plugging along. So the way that this slide is laid out is this first line of treatment, and I might actually suggest that this would be more kind of baseline treatment. So this is something that won't go away, and it's something that people should be doing from the very beginning all the way to the very end. And so having a good exercise regimen is of paramount importance. I talk about that with almost all of my patients, the importance of exercise. That's important for everybody, but we also know that it's very important for the functional status and maintaining function over the course of Parkinson's disease. And we now have data to support that, when, previously it would really be, kind of that common sense recommendation. Yes, we know exercise is important, and we know it's important for everybody. We know it is especially important in Parkinson's disease, and it is as important as any of the medications that that we recommend. Having, a regimen of rest and relaxation and stress management, that is something that looks different for everybody. Sometimes that includes, hobbies. Sometimes that includes, a dedicated time of mindfulness or meditation, or prayer, which, or something along those lines. Nutrition is also is important. I get asked quite a lot from patients, especially early on, if there's a specific, diet they should be following. And if you go looking on the interwebs, you'll find a couple of different recommendations. One that's gained popularity, within at least the past couple of years is, and I've heard some people talk about, is like following a ketogenic diet or something along those lines. I don't tend to prescribe to that too much. I have, the benefit from a movement standpoint is relatively modest, and I have some, questions about what the, effects of maintaining such a diet would be long term. But by and large, we should be having a diet that is, high in fruits and vegetables and lean meats, and avoiding things like packaged foods and sugars and things of that nature. So that's kind of again fairly a generic type of recommendation. Sometimes people also there's at least some evidence to support like a Mediterranean diet, or the combination of a Mediterranean diet and DASH diet. But again, that evidence is not ironclad, I guess I'll say. So, and then I also, really put a lot of weight in rehab, PT and OT and speech therapy, really from the very beginning of things to, the very end of things. And so, throughout the course, PT and OT and speech have a role to play, and can really help with maintaining function. And then, mental health counseling, which we'll talk about a little bit as well, a little bit later. And then being educated, and that, this is part of that, and being part of these support groups, which, people find a lot of comfort in and value in and camaraderie in. And so, again, thanks to the Michigan Parkinson Foundation for all the work that they do with my patients and the other patients with Parkinson's disease in the area. So when it comes to medication, the first and foremost, we don't have anything, at least currently available, that would be what we call disease modifying. We don't have a cure, and we don't have anything that slows down the progression of Parkinson's. The progression of Parkinson's is different for everybody. Sometimes it's really quite slow and, only results in fairly mild, symptoms that are a nuisance. I wish that were the case for everybody. That it clearly is not, and other people progress more quickly. But everybody has a different course and a different rate of progression, and we kind of take that one person at one case at a time. But while we don't have anything that's quite disease modifying nor curative, we do have a number of medications that we use that we call symptomatic therapy. So meaning that it reduces the symptoms of Parkinson's disease. And these really can be quite effective, and can help people maintain function and maintain, doing what they want to be doing, enjoying, their hobbies, enjoying, being with family and friends, and participating the things that they want to be participating in for a long period of time. So then the question becomes, well, if it's only symptomatic treatment, when do we start them? And that by and large might be, kind of when the motor symptoms are bothersome. And when I say motor symptoms, I mean tremor, I mean stiffness, I mean changes in dexterity, such as, that cause difficulty with fastening buttons or tying shoes or getting dressed or using utensils, perhaps with handwriting. Those types of things are what I'm referring to. And the point at which things become bothersome may be a little bit different for everybody. The one caveat to that I will say is that we will often start medications sometimes for patients when we examine someone and your neurologist thinks, you know, I think this might be Parkinson's disease, and they may want to start a medication, and that can help us from a diagnostic standpoint in confirming that one has Parkinson's disease or perhaps something that looks like Parkinson's disease and isn't. You know, at the end of the day, this is something that, again, is progressive and symptoms change over time. And so that means that we need to continue to monitor how symptoms change and adjust our treatment and our therapy accordingly. The important thing here is that I think, you know, I want to highlight is that many people will tell me, you know, that they want to, you know, not take medication because they're concerned that they, you know, want to kind of save the use of medications for a rainy day or save it for when you really need it. That is maybe not quite the right way to think about the treatment of Parkinson's disease. You know, or that people get this idea that you build up tolerance to medication over time. And truly the point I'm trying to make here is that because things change over time, because the, you know, Parkinson's disease changes over time, that we need to change medications. And just because we're changing medications doesn't mean that we are, you're building up a tolerance to the medication per se, but it does mean that you know, we're still needing to, you know, change things because there's things going on underneath the surface that need to be changed. Point here then. So, as I was mentioning, so, you know, in newly diagnosed Parkinson's disease, we might end up holding off on the start of medications until we need, you know, until the symptoms warrant starting a medication. Most often we'll start with one particular medication. For initial, you know, treatment with Parkinson's, there are often a number to choose from. And the, you know, thing that we learn in medical school is, you know, you start low and go slow. And so that's typically the paradigm that we follow, is you start with low dose of medication and then we adjust it and build it up as, you know, the symptoms require. And, you know, because of Parkinson's disease and the way that it behaves, as well as the interaction of Parkinson's disease with the medications that we use, that as time goes on, we may need to increase the number of times someone takes a particular medication during the day, or we may need to use multiple medications in order to achieve good symptomatic control during each person's waking day. And, you know, again, no people respond the same to medication. So there's a whole list here of medications from Levodopa all the way down to these Adenosine A2a Antagonists. I'm going to go over each one kind of individually. So the first one that we'll talk about is Levodopa. This is by far the most commonly used medication in Parkinson's disease and remains the most kind of potent medication and effective medication for reducing the symptoms of Parkinson's, kind of milligram for milligram, pound for pound. This comes in a number of different formulations. The one that we use the most is something called Sinemet. And so I often will use Levodopa and Sinemet kind of interchangeably, unless someone is taking, one of these other specific medications. And so the idea here is that in Parkinson's, there is a lack of dopamine being produced in the brain that ends up causing these symptoms of stiffness and slowness and tremor and loss of dexterity. And, quite simply, when there's not enough dopamine, we're trying to replace that dopamine, and we do so with the addition of levodopa. We can't give people dopamine, directly, because dopamine doesn't get into the brain. And so what levodopa is kind of the direct metabolic precursor to dopamine. So levodopa gets converted directly into dopamine once it enters the brain. The one that we've had around the longest is Sinemet, and then there's a number of other formulations like Sinemet CR that was originally designed to be a longer acting formulation of this medicine. One that does probably a little bit better job of being a longer acting and evenly acting medication that we call Rytary. And there's also a pump form of levodopa that is called Duopa, that I have a slide about a little bit later. And then there's something called Parcopa, which are these kind of blue disintegrating tablets that are basically the same as Sinemet. It just is a dissolvable form of Sinemet. This is kind of, as we refer to it, the gold standard. My mentor actually refers to this as the quote unquote platinum standard of the treatment of Parkinson's, and really is, again, milligram for milligram, probably the best medication that we have in terms of reducing the stiffness, the slowness, and the tremor, as well as some of the difficulty with walking. So these are this last bullet point is important. We expect this, what we call bradykinesia, which is slowness of movement, as well as rigidity, which is the stiffness in the muscles, to get better on levodopa in the setting of Parkinson's. Tremor is a little bit tricky, and tremor can be very responsive to Sinemet, and it can also not respond quite so well. And so one thing to keep in mind is that if your doctor starts you on Sinemet and we are only paying attention to tremor, sometimes the tremor won't get better, and this conversation arises of, well, it didn't do anything for me, and so I don't want to take it anymore. So there needs to be a little bit of the right perspective in terms of what we're looking at to get better in the setting of Parkinson's. The walking thing is complex. Walking is a complex movement that we do as humans, and walking speed often improves on Sinemet. But if there's significant issues with balance, balance is something that generally won't or doesn't get better with this medication. The side effects that we're typically looking at are lightheadedness, dizziness, drowsiness, and nausea. Nausea is probably the most commonly encountered side effect of it. In fact, Sinemet, when it was originally designed, literally means without vomiting. And it got that name when we discovered that this first part of that medicine, called carbidopa, is something that prevents the dopamine in the blood from causing the more severe nausea and vomiting. And so with the carbidopa in combination with levodopa that we know as Sinemet, it really reduces significantly the amount that people experience these side effects that are listed here. The last one that we refer to as motor fluctuations and dyskinesias, those are later findings. Those aren't something that would happen immediately. Motor fluctuations are kind of this up and down variable response of symptoms during the day. And so you might take your levodopa in the morning and symptoms get better for a while, for a couple of hours. And before you're due to take your next medication, you feel the return of tremor, you feel the return of that stiffness and slowness before you take that next dose. And that can happen then continually during the day. You take medication, symptoms get better, then they get worse again, and you take more medication. And so that pattern we refer to as motor fluctuation. Dyskinesias are these kind of unwanted, involuntary, excessive movements of the arms or legs or the head and neck that has more of a kind of a dancing, twisting, turning type of a quality to it. That can most often be a result of having the kind of peak dose, too much of the Sinemet, of the levodopa in the bloodstream. So I kind of already discussed that. Dystonia, which is kind of this twisting, cramping, abnormal posturing of the limb, can also happen. It's interesting, it can happen because of the Parkinson's. It can also happen because because of the levodopa that we use to treat it. The most common one that we encounter tends to be this, kind of foot and ankle dystonia, where your ankle might kind of turn in, or the toes might want to curl underneath the foot, or something along those lines. Next up are what we refer to as dopamine receptor agonists. These are medications that the substance basically, chemically resembles dopamine, but really isn't dopamine, and so it latches on to these dopamine receptors in the brain to activate them to try to accomplish the same things that we're trying to accomplish with levodopa: reduction in stiffness and slowness and tremor. There are a number of different formulations of dopamine agonists. One is called pramipexole. The trade name there is Mirapex. Another one is ropinirole, also called Requip. Those are both oral, pills that you'll take during the day. They have both immediate release formulations where you might take it, 3 or 4 times a day, as well as extended release formulations, which are just single day, once a day dosing. There's also what's called rotigotine, which is Nupro, which is a transdermal patch that you apply once a day, again, with the idea of having more continuous administration of this medication. And then there's this thing that we call apomorphine, also known as Apokin, which is an injection that is really more used kind of on an as-needed, on-demand basis that's much shorter acting than the other medications there on that list. There's another new medication that of apomorphine that's called Kinmobi, which is a film that goes underneath the tongue. I think I'll talk about that again. I've got a slide a little bit later to discuss that more specifically. And if you go online, you might read of a couple of other medications that fall in the same category, like bromocriptine or cabergoline or pergolide. Those aren't really used any longer. So again, these are acting as like a mimic of dopamine, even though they aren't dopamine, and is used either often alongside Simet to try to smooth out some of those motor fluctuations, or can be used early in the course of Parkinson's disease all on their own. Here, it indicates that maybe be used in early PD, younger than 50 years old. I probably would say, under 60 or 65 is where I used it the most. Once people get into their, over 70, into the mid 70s, people tend to not tolerate the medication quite as well. And we often end up having to eliminate the medication in lieu of something like levodopa. There's also a thought process that the use of this medication early is kind of what we refer to as a dopamine sparing therapy. So to use this before we give someone levodopa, that it might reduce the emergence of those dyskinesias and motor fluctuations. I think that there's relatively good evidence at this point that that's not truly the case. Although younger than 50 in a young onset Parkinson's disease, there might be more of a reason to use a dopamine agonist. People with young onset Parkinson's develop dyskinesias at much higher rates than people with Parkinson's disease that develops in your 60s. Side effects are very common, very similar to what we see with levodopa, with a couple of additions. The drowsiness that can occur with Sinemet is probably a little bit more prominent when with a dopamine agonist. On very rare occasions, it can even cause this thing that we refer to as sleep attacks, where people just are like awake and then suddenly sleeping. People don't, get that out of the blue. They will have drowsiness as a side effect at baseline, and that might be even worse with some add-on of these kind of sleep attacks. I've seen a couple of patients that have developed these on these medications. They're really quite rare. It can cause some edema in the legs, and so if you start taking this medication and you start getting some swollen ankles, that may be the reason why, and might be a reason to get rid of that medicine. And then the one other kind of idiosyncratic side effect that these can cause is something called impulse control disorders. Impulse control disorder is basically new onset of a new habit that you do to the exclusion of basically everything else. So common examples that we talk to people about are compulsive shopping, gambling, hypersexuality, but I've even had people develop it in a way that I had one of my patients that was building model planes in his garage all day, every day, and doing nothing else while on the medication. And once we got rid of it, then he was able to, he still enjoyed building model planes, but he was able to do the other things that he was supposed to be doing during the day. And so if those develop, then your doctor needs to know immediately, because they can be really quite problematic, and we need to withdraw the medication in those settings. Next medication they'll talk about are these things that we refer to as Maob inhibitors. The one that's specifically marketed for Parkinson's disease is this Receptor medication, also called Azilect. Selegiline is another medication that's a little bit older that basically is very similar in its mechanism of action and efficacy. Dopamine, while it's in the brain, gets metabolized and broken down by two different enzymes. One of those enzymes is monoamine oxidase, MAO. And so what selegiline and rasagiline do is they slow down or block the action of MAO, and that allows dopamine to hang around in the brain longer. And so it can help us in a couple of different instances. Some of it can be used initially with very early and very mild symptoms of Parkinson's, but very often we will use them to try to extend the length of action of Sinemet, try to make that last longer, try to treat some of those motor fluctuations that I was describing earlier. Initially, we thought that Azilect, which is rasagiline, might have some neuroprotective properties, that it might slow down progression of Parkinson's. But I think common knowledge at this point is that that's probably not the case. It's really kind of it's a maybe kind of it could type of thing, but really I think that the idea that it's neuroprotective has largely been abandoned by the medical or the movement disorder community. In short, basically what happened was what the studies that brought this to market, the rasagiline, tested three different doses. With one of those doses, the 0.5 milligram dose, we saw that after people were on this medication for 52 weeks, that the people that were at that 0.5 milligram dose seemed to progress more slowly than people that were on placebo. However, we didn't see that same effect with either of the other two doses that were higher doses that were tested. And so we're left trying to explain this idea of, well, if the 0.5 milligram dose slowed things down, why doesn't 1 milligram? And so I think that there's something else going on there, and I think that's been the explanation from people even smarter than myself that that really tore this study apart and analyzed it quite deeply, and I think that we are in a position now where we really don't feel as though it is protective in any way. One other thing that you need to be aware of with this medication is that it can't be taken with Demerol, which is meperidine, which is a synthetic opiate medication that was used for pain. There's also some caution to be used with if you're on other antidepressants. Truly, I mean, it can be used very safely with other antidepressants. For selegiline, used at high doses, higher than recommended doses in Parkinson's, you could potentially have an interaction there. But if you're on Azilect or rasagiline, there really isn't much that you have to be worried about. The selectivity of the MAO type B allows us to use it safely with other antidepressants. I mentioned just a moment ago that there's two different enzymes in the brain that metabolize and break down dopamine. One was that MAO, the other one is called COMT, which is short for catechol O methyltransferase And that's that second enzyme that breaks it down. So again, if you inhibit COMT, just like if you inhibited MAO, there's more dopamine around to try to, treat your symptoms. This the one that we've had around for a very long time is something that's called entacapone or Comtan. This also comes in a combination product of carbidopa, levodopa plus entacapone, also called Stalevo. And the way that entacapone works is that it prevents the breakdown of levodopa, and this is mostly in the intestines. Some of it is in the brain. And we use this alongside Sinemet to try to improve and manage some of those wearing off symptoms, some of those motor fluctuations that we've talked about. The side effects of this medication include worsening dyskinesia, those extra involuntary movements, nausea, dizziness, diarrhea, some abdominal cramping. Most of this is a feature of increasing the level of levodopa in the blood because it has to be taken with Sinemet. The last one that isn't listed here that's a little bit strange is that it can turn your urine kind of orange. And so if you start taking entacapone and you get an orange color to your urine, don't be alarmed. And it is just a side effect of the medication. There's one other new medication called opicapone or Ongentys. This is a newer COMT inhibitor that's been released in the United States. It's been available in Europe for a couple of years. This does a better job of getting into the brain and preventing the breakdown of dopamine in the brain itself. And so, and it is not used with every dose of Sinemet. It is a once daily dosed medication that is taken along, with your normal daily dosing of Sinemet. And so, another welcome addition to the treatment of Parkinson's. Kind of simplifies things without having, with taking one dose of a medication once a day rather than having to take another medication on top of your Sinemet. Next one, Amantadine, also called Simetrol. This is an old medication that was originally designed as a flu medicine, believe it or not, and it has a number of different mechanisms of action. But basically, the two instances in which we use this is to improve tremor and Parkinson's. Remember that not everyone responds really well in terms of their tremor when they're on levodopa. Sometimes people take levodopa and their tremor doesn't get that much better. And so sometimes we have to use a different medication just exclusively for trying to reduce tremor when it becomes bothersome. It also is used to try to reduce the emergence or incidence of these levodopa-induced dyskinesias. Again, those excessive, unwanted, involuntary movements that can occur after taking an orally administered dose of Sinemet. These drugs are mostly used in people under the age of 60, under age of 70, because again, just with some of our other medicines, as we get older, we tend not to tolerate the side effects of medication very well. So specifically for Amantadine, we're worried about it causing, cognitive changes, confusion, hallucinations. It also can cause dry eye, dry mouth, and constipation. It can also cause some swelling in the legs. It can also cause this kind of lacy-like rash that occurs on the legs called livedo reticularis. I think that's listed here. Recently, we've had a couple of other brand name medications called Gocavery and the other one called Osmolex. These are extended release formulations of Amantadine that can be taken once a day. And some evidence, that they do a better job at reducing dyskinesia than the 2 or 3 times a day someone might be taking, immediate release Amantadine. Let's see, I think that's really about all I've got to say about Amantadine, but they really, you know, in terms of having a use of medication for special circumstances like dyskinesia or like tremor, these can be really quite useful. Again, as a kind of special circumstance type of medication, Trihexy Phenodyl, which is also known as Artane, can be very effective for reducing Parkinson's tremor. This one tends to be probably the least tolerated medication that we use, and really is primarily used for people who are in their 50s, maybe early 60s, with really quite significant tremor, because just too often it's just not very well tolerated. Another one that's very similar is called Benztropine. I don't tend to use this medication very much in the setting of Parkinson's. And as I said, this, you know, might have some mild reduction of the stiffness and rigidity in Parkinson's, but is primarily used for reducing Parkinson's tremor. All of the medications that we talked about so far are basically aimed at influencing the way dopamine works in the brain. Either we're giving you dopamine directly in the formulation of Sinemet, Levodopa. We're trying to, you know, use a medication that is like a dopamine mimic, like a dopamine agonist. Or we're using medications that are designed to try to make the Sinemet work better. There's this newer medication that's called, they're in this family called Adenosine A2a Antagonists. This is a medication that's been available basically this year. It's known by the trade name Neurians. Its generic name is Istradephylene. Basically, this is trying to give an assist, you know, to the Sinemet someone might be taking. So it does have to be used concurrently with Levodopa, but it's working on neurotransmitters in the brain, specifically one called GABA, to try to even out some of those motor fluctuations and kind of even have that even response of symptoms during the day. And so this is either a 20 milligram or 40 milligram tablet that is taken, again, once a day, just like that other medication that I mentioned, which is helpful, you know, because we take a lot of medications in Parkinson's disease. And so it's, you know, whenever we're able to give someone a tablet they take only once a day, you know, that's very, you know, desired, because, you know, we just take so much. It can be really, you know, it's at least a novel medication. This is, you know, something that we've not had before. And so it's always nice to have something that is new and something that works differently than other medications that we've had available. Also, something that has really come into the spotlight within the past year or two are these kind of rescue therapies for off episodes. Sometimes people experience these off episodes very unpredictably, and so it's helpful to have an as-needed, on-demand type of treatment to alleviate some of these off periods that might occur unexpectedly, or to treat something that we refer to as kind of morning akinesia, that symptoms are, you know, much more significant first thing in the morning because you've gone all night, slept all night without having had any medication. And so the one that we've had for the longest is something called Apomorphine. This is an injection that comes in a pen that you give yourself that is very rapidly acting and can alleviate those symptoms on an as-needed basis. More recently, we've had two new medications. One is something called Embrysia, which is an inhaled form of levodopa. It comes in this blue inhaler, very similar to like what you think of with an asthma inhaler. And you inhale this powdered formulation of levodopa, and the advantage of that is that it gets to bypass the absorption that is required from, you know, through the stomach and what we call first pass through the liver, which is part of the reason why it takes so long for the medication to kick in after you take an oral dose of levodopa. And so being able to bypass that whole thing and just inhale it allows it to get directly into the bloodstream and act much more quickly than an oral medication. While it does kick in very quickly, it doesn't last quite as long, about 30 minutes. And I guess there's another slide coming up in just a second that will show you that. Kinmobi is another formulation of apomorphine. This works very similarly in terms of concept, that you're using it as needed on demand, and is very similar to like those little Listerine mint strips that we used to have, where you place it underneath the tongue, allow it to dissolve, and it gets absorbed through the mouth. Again, with the idea of being absorbed directly into the bloodstream and being able to act very quickly. So here's that picture of that inhaler of Embrysia. These are two 42 milligram capsules. You do 2 capsules at once. So it's one directly followed by the next one. And you inhale that deeply into the lungs, and it kicks in within about 5 to 10 minutes and lasts for about 30. May be difficult to do in that very morning akinesia off, quote unquote off state. Although they did look at that in the clinical studies and claim that people, even while off, were able to use this on their own without assistance. Side effects are all very similar to the levodopa that we know and love, but because it is an inhaled form of it, the things that are unique to Embrysia are mostly cough. But it can cause some dizziness and headache as well. This is a little graphical representation of the use of this medication. And so you can see this dotted line is placebo, and the solid line is the score for the use of the medication. And so what's on this y-axis here is the change in the motor examination in Parkinson's. And so we use this thing that we call the UPDRS, which is the Parkinson's disease rating scale. And so we're seeing an improvement in symptoms, which is what all these negative numbers here are, is that we see an improvement in that score over the course of 10, 20, 30 minutes. And so versus placebo, what we're seeing here is about a 10 to 12 point improvement, which is substantial, in the UPDRS over the course of 30 minutes over placebo, which improved by just a couple of points. And we see that effect is sustained for about 30 to 60 minutes and then wears off. Here is the schematic of Apokin, which is another one of those kind of quote unquote rescue medications. This is what that pen looks like, and the capsule of the medication that you would use, and which is good for multiple different doses. And it can be, again, very effective in that, alleviating symptoms very rapidly. Its side effects are very similar to the other dopamine agonists that we discussed earlier, with the exception that it can cause pretty significant nausea and vomiting. And so it sometimes does need to be co-administered with a nausea medicine like Tygan. And the other side effect is that because of the injection site, that some people will develop some nodules underneath the skin. There we go. And then again, as I had mentioned a couple times already, there's this newer medication, also a formulation of apomorphine like Apokin is. This goes by the trade name of Kinmobi, and is administered under the tongue, where it gets dissolved and rapidly reduces the symptoms of Parkinson's, gets people back to that quote unquote on state very quickly. It has multiple different doses, and these get started in a titration pack. And so you start with the lowest dose, and we slowly build those up to the point where you get to your best on state, and we kind of just find that dose slowly by starting with the lowest one and increasing in a stepwise fashion. So that's pretty much all of the medications that I'll talk about as far as the ones that are used for what we call the motor symptoms. So stiffness, slowness, dexterity, tremor, those types of things. Next here, I'm going to discuss a couple of different kind of special circumstances for treatment of what we refer to as non-motor symptoms. So some of these other things that you'll see listed here, like REM sleep behavior disorder. REM sleep behavior disorder is something that is basically dream enactment. And so you might have your doctor ask you if you yell out or punch or kick or flail around or talk in your sleep. And this is a manifestation of your dreaming, and normally we're also, our bodies are paralyzed in that dream state. And that mechanism becomes impaired in Parkinson's disease so that people are able to move around and yell out in their sleep. If that happens and it's relatively mild, we can try melatonin, which is a natural sleep supplement that can be picked up over the counter. Most people use this in doses of 3 or 5 or 6 milligrams at night, about an hour before bedtime. For the best data that we have available, we probably need doses a little bit higher to treat REM sleep behavior disorder. Doses probably somewhere between 10 and 15 milligrams. If that is not effective, clonazepam or Klonopin can be effective at small doses to be taken at bedtime. That's what that HS means at the end of that sentence. And the clonazepam, we actually have really good evidence, does a very good job at reducing that dream enactment. That might seem like a benign type of a symptom, but people have injured themselves, or they have hit or struck their bed partners, spouses, and so then people start sleeping in separate rooms because that's happening, and so it can really be quite disruptive. And so it's important for your doctors to know about and for us to kind of treat appropriately. Constipation is another big one. We run into constipation all the time in Parkinson's, and it really is quite important to manage. This is something that we're very often able to take care of with, making sure we stay well hydrated, drinking enough water during the day, maybe adding a fiber supplement or eating foods that are high in fiber. Your kind of pea fruits, peaches and prunes and things like that. But apples, prunes, figs, raisins, bran cereals or oatmeals or things like that can help. If very often those interventions, those most conservative interventions, are not sufficient, and we may need to add either a stool softener or something like Miralax. And it's important to get to a point where you're moving your bowels every day or every other day. When it's less often than that, then we can really run into some problems. We see a lot of anxiety and depression in Parkinson's. We see this at higher rates than we see in the general population. And so we know that anxiety and depression are just as much part of Parkinson's disease as the tremor is, and is something that we really need to be aware of and treat as much as we treat the other symptoms. And so this might be something that is effectively treated with, doing some meditation and some mindfulness. Maybe we require talking to a therapist or a counselor to, work through some of these issues that, dealing with. We've seen a huge uptick in the amount of complaints of anxiety and depression, especially this year, as everybody's having such a difficult time. And staying at home so much more and having less contact with people. And so we're really seeing this quite a lot, even more than normal. And we very often will need to add on some medication to address the mood, just like we're addressing some of the other symptoms in Parkinson's. And then lastly, on this slide, apathy kind of being tied into that mood and behavior piece of things. And we see this, as time goes on. Sometimes we might use some medication for this, although, we are often able to get a hold of it with some other antidepressants. The other instance in which we see this is after deep brain stimulation surgery, when people rapidly are able to reduce the amount of medication they take, that it can cause this kind of withdrawal syndrome and cause people to feel apathetic. Orthostatic hypotension and supine hypertension are those next bullet points. Those two really go very much hand in hand. orthostatic hypotension means that when you stand up, that your blood pressure abnormally drops to a level that's unacceptable and can often lead to a sensation of lightheadedness or dizziness or weakness or kind of a painful sensation across the shoulders, weakness in the legs, and in its most significant form can cause people to lose consciousness and faint and result in falls, which is why it can be really quite a problem. Again, staying very well hydrated is of paramount importance, first and foremost, to treat orthostatic hypotension. But again, this, in addition to this next bullet point of supine hypertension, Parkinson's disease affects the nerves that are responsible for regulating our blood pressure. And so our blood pressure can become very, very unpredictable, very, what we call labile, and kind of be really low and then go really high, and is, again, just it's part of the disease. And so when we're getting to a point where blood pressure is dropping sufficiently to cause symptoms and to cause lightheadedness or fainting, it requires the use of some medications to support that blood pressure to keep it from falling abnormally. The ones that are probably most commonly used are a medication called Midodrine, and another one that's called Droxidopa or Northera. Droxidopa is approved specifically for Parkinson's disease and a couple of other conditions related to it, and can be very effective. Both of them can be very effective and appropriately supporting blood pressure. Supine hypertension is this phenomenon by which when you lie flat on your back, blood pressure can actually elevate quite significantly. And this is something that, again, may be going on the whole time and you're completely unaware of it. And that's okay. And it's one of those things that we, if it's really high, we need to be aware of and address. But this is one of those things where we have a very reactionary type of philosophy, or especially in this country, to high blood pressure. We don't have very good data about the long-term consequences of supine hypertension and kind of these intermittent, types of elevations in blood pressure, even when it gets quite high. And so, the comment that's, here is that it can cause organ damage and increased risk for stroke. And we, at least on some level that may be true, but we need to be a little bit cautious with the way that we, react to it. And, that we tend to have this kind of Pavlovian type of reaction to high blood pressure. And so something to be aware of, but something that, can be treated relatively conservatively. Again, just with the anxiety and the apathy that I mentioned in the last slide, depression is a big problem that we run into and have been running into even more recently. And is, again, part of the disease process. It is part of Parkinson's disease when it happens. And so, again, considering having a counselor or a therapist can be highly beneficial. And then sometimes we will need to add on a medication to try to address and elevate that mood. Fatigue is a big problem. This one's really hard for, I hear this complaint often and a lot. As many as 50% of people with Parkinson's suffer from some degree of fatigue. Some of that is related to, the symptoms of stiffness and slowness. The way that I've described it to people is that it's, imagine going through your entire day, walking through a bowl of oatmeal that, or Jell-O, that you have to exert so much more effort just to do simple things. And that, invariably results in some fatigue. But even absent that in the setting of milder symptoms or well-controlled symptoms, fatigue can be a big issue. And so the first thing that we try to do for people is to try to have good sleep hygiene, which means having a bedtime routine, going to sleep at the same time every night, getting into some pajamas, brushing your teeth, and, not doing anything that's particularly mentally stimulating, like watching television or something like that. And to try to limit the amount of naps that are taken during the day. When really truly interfering with the ability to just be awake enough to go about your day, we may need to add medications like Provigil, Nuvigil, Modafinil to promote that wakefulness. Next, drooling is something that occurs to varying degrees in the setting of Parkinson's. When mild, we can suck on some hard candies. I generally recommend like a sugarless lemon drop or something like that, which helps stimulate people to swallow. Chewing gum or sugarless chewing gum could also be accomplish the same thing. Sometimes we'll use some of these Atropine drops. They're actually like eye drops, but we kind of repurpose them to be put under the tongue that can basically dry out the mouth. One of the side effects of Atropine is that it causes a lot of dry mouth. The way that it does that is very similar to the way dry mouth is created by Amantadine or Artane, which are some of those medicines that I mentioned earlier. When those aren't effective, we might use some injections of botulinum toxin. So we commonly know this as Botox. When I do this for my patients, I tend to use a different product called Myoblock because it tends to cause a little bit more dry mouth as a side effect, which is what we're going for. And the parotid gland is one of the largest salivary glands. And so there's one, it's basically at the corner of the jaw the injection, and it's pretty quick and easy. I tend to do those two as well as a couple underneath the chin, depending on how significant the problem is. Urinary changes in urinary frequency. Man, this is something that we run into a lot and is difficult because it has many different causes. It can be caused by other medications. It can be caused in women, after, childbirth, and, that can be, after you've had some kids and that the muscles there have become weak, that there can be some urinary frequency and problems there. In men, as we get older and develop enlarged prostate or things like that, that can cause some of these types of symptoms. And so there are a number of reasons why that might happen. And so it's important for us to realize that not everything that you experience is caused necessarily by Parkinson's disease, and that we have to make sure that there's not something else that's going on that's causing a particular symptom. But assuming that we've ruled out something else that's causing it, and we can be assured that it is related to the Parkinson's disease, there are a couple of things that can be used to slow that down, to alleviate some of that frequency and urgency to have to go to the bathroom all the time or right away. Myrbetriq is one medication. Mirabegron is the generic name there. That can be used very well. There's basically three medications I use in this instance. Myrbetriq is one. There's another one that's called Vesicare, whose generic name is sulfenicin, and there's a third one that's called trospium or Cinctura. Each of those three tend not to get into the brain very well and tend not to cause much in the way of side effect. The one that we get most worried about is confusion and hallucinations, and so those three cause that side effect the least and are really the medications of choice if we're going to use one in urinary frequency and urgency and Parkinson's. And then got a few slides left here. As time goes on, some people will develop some cognitive changes as a result of having Parkinson's disease. We should, if we're doing our job, be screening people for these changes and be doing something that's called a MoCA, which stands for Montreal Cognitive Assessment, and doing that, annually, or if there's, some reason to be concerned. And in the setting of Parkinson's disease dementia, then there's some medications like ribostigmine, Exelon, or donepezil, which is called Aricept, that can help slow the progression of the memory loss and improve some clarity and memory during the day. And as many of you may have seen on commercials that have been pushed on television, hallucinations can occur in Parkinson's. And we see this as a matter of Parkinson's itself. We also see it as a matter of some of the medications that we use to treat Parkinson's. And so there's some medication adjustments that may need to be done first. We may need to reduce the dose of some medications, discontinue other medications in order to address the problem if people develop hallucinations. If those are not effective, then using a medication like Nuplazid might be indicated. And this is a medication that's approved specifically for hallucinations and delusions in Parkinson's disease, and can be really quite effective. It's the only medication that is approved and has the indication for it. Another medication that many people might be familiar with or have heard about is something called quetiapine or Seroquel. This is a medication that we've used commonly as physicians without having really great data that it works very well. But we have anecdotal evidence that it is effective, and it's been used traditionally because it's one of the medications in that family that has the lowest risk of worsening Parkinson's symptoms, and that's part of the reason why it's been used. So, I should mention first before I move on here, I've gone through a lot of different symptoms here. There's a lot of different things that I've mentioned, from, cognitive changes to urinary changes to drooling to, what have you. It's important to remember that these are all things that can happen, that we do encounter from time to time, but are not necessarily something that is going to happen or has to happen. No one person experiences all of these symptoms. And so it's really kind of like, the idea of like a, Parkinson's buffet. Like your body will choose a couple of these symptoms maybe to experience. And some people may experience more than others. But, it can be really quite distressing to read it, see me go through all these different things that, can happen in the setting of Parkinson's. And we take these one thing at a time, one issue at a time. And no one, again, experiences all of them. The timing of medication is really important for treating Parkinson's, especially as time goes on and people get into the moderate or advanced stages of Parkinson's. People really, rely really quite heavily on when their medication is due in order to maintain an even improvement in symptoms during the day. We have to, monitor and adjust as time goes on, because this is something that is, is not static. It changes with time, and so we have to adjust with it. And side effects emerge over time, or side effects emerge as we adjust medications. And so it's something else that is a challenge for us to deal with. The other thing that comes to mind here is that sometimes we run into a situation like when people are having hallucinations, where I'd love to be able to, increase their medication to improve the stiffness and slowness, but in order to do that, the hallucinations might get worse. And in order to improve hallucinations, I have to reduce the medications, but as a result of that, stiffness and slowness gets worse. And so you kind of are trying to strike the right balance in order to, get the best outcome that we can. Especially with some of these newer medications that have come onto the market, cost is also an issue. Sinemet is 50 years old and is pennies to the dollar, but some of these newer medications can be really quite costly. And so it's something that we have to consider, in all this, is how much benefit are we getting with some of these newer, and better types of medicines, that the amount that you're spending on these medications, because there are a number of them, also needs to be in consideration. I'll talk really quickly here about surgery because this is really supposed to, we're really trying to focus more on some of the medications, but as our medications fail to adequately provide relief of symptoms and fluctuations during the day or dyskinesias, those excessive unwanted movements, you may discuss some other more advanced therapies, such as deep brain stimulation, which is the implantation of, I think there's a picture here. Oh, there it is. An electrode that's about the size of a strand of thin spaghetti into one of a couple of different areas in the brain. And this delivers high frequency pulsatile stimulation and can be really quite effective in evening out symptoms during the day, reducing those motor fluctuations, improving upon the excessive unwanted dyskinesia type of movements. It can be really quite profoundly effective for reducing tremor in Parkinson's when our medicines aren't effective. And so is a really great tool and has become part of the standard of care in the treatment of Parkinson's disease over the past 15 to 20 years. Duopa is another advanced therapy, which is an intestinal gel of levodopa that gets pumped through a tube that is a J tube. So it goes through the skin directly into the stomach and into the small intestine, right where it gets released, right where the levodopa is best absorbed in the small intestine, in an area of the intestine called the jejunum. And so you get this continuous infusion of levodopa during the day over 16 hours of the day, and again is a very highly effective treatment for managing the fluctuations, ons and offs, as well as dyskinesias that can be experienced in Parkinson's. In terms of other management with therapies, as I mentioned at the outset, I use physical therapy and occupational therapy from the outset and use it throughout the course of Parkinson's. It can become very beneficial and of paramount importance with some of these symptoms that our medications fail to address, such as poor balance or falling or freezing of gait, as well as having occupational therapy to try to improve, or use different tools or techniques or strategies to be able to accomplish activities of daily living that our medications are not allowing someone to do on their own, and difficulty swallowing or having speech that's become very soft or difficult to understand. Again, our medications don't really fully address that symptom at times, and speech therapy can be quite useful. And then we've already kind of talked a little bit about mental health on some earlier slides. And this is something that we have to remember is, this is something that first and foremost affects patients, but is, we're all in this together, from patients to caregivers and physicians. And so, having social work to help with some of the other services that might be needed, or some of the support that family and patients and caregivers may need, is also something that's highly effective. And then again, as this is something that we don't have a cure for, sometimes people will progress to a point where our medications are doing very little, and we have to, might want to change our focus from maximizing function to maximizing alleviation of pain and discomfort. And so that's the situation in which something like palliative care might come into play. No matter what, our goal is to reduce, the incidence and severity of symptoms. And from the very beginning is, to try to maintain one's independence for as long as possible. And as I, just alluded to, this is a team effort. This is, from physicians to speech therapy, occupational therapy, physical therapy, patients, caregivers, social work. This is a marathon. It's not a sprint, and it really requires a lot of people to, no one person is going to be able to do this all on their own. And so it really requires a team effort. We have, as always, research that is ongoing, looking into what exactly causes Parkinson's disease. Some very interesting, and encouraging medication trials that are in the pipeline that we will hope will be able to change that statement where I say I don't have anything that slows it down to, look, we have this brand new medication that reduces the progression of Parkinson's disease. And there's other medications that are in the pipeline, like subcutaneous pumps of apomorphine, or subcutaneous pumps like an insulin pump of levodopa, which again will be a welcome addition to the armamentarium that we have to treat symptoms of Parkinson's. And so this is a disease that we all are in together, and is, as you can see, something that's very complex, or as you can have experienced, is something that's very complex. It involves many different body systems. Everyone experiences their symptoms a little bit differently and at different times and at different rates. It takes a lot of time to understand about Parkinson's, and people like myself spend our entire careers trying to fully understand Parkinson's, and so this is a lifelong endeavor. And finding the right care, which is more than just medications, is about finding the right physician, the right team, the right therapists, where you feel comfortable is essential. So that's kind of the end of my time, the end of the slides here. And if there's any quick questions, I'll be happy to try to address them.
Dr. Kuhlman, thank you so much. I know that I provided a lot of content for you to cover. And I also want to reiterate what Dr. Kuhlman said earlier. All those symptoms, there's a lot of symptoms, and as Dr. Kuhlman said, you might have 2 or 3 of them, but to cover, everybody's different, so we covered all of the possible symptoms. I know it can be a little overwhelming. Dr. Kuhlman, I know that this was a lot. If you have to get back to work, let me know. If you can take a few questions, let me know.
Yeah, I've got a couple of minutes here left to take
Okay.
a few quick questions if they're out there.
If you can put the questions in the chat box at the bottom. I do see one question about, it said, whatever happened to stem cell therapy?
Oh yeah, that was a slide there that I didn't really address. So let me pull up the chat. So that's still something that is, has a lot of excitement, and is something that, is in the pipeline. So the pace at which medicine moves is far slower than any of us would like. There's a couple of challenges that we're still trying to resolve in the setting of stem cell therapy. One of the first ones, when we first started this, was, that the types of stem cells that we were using had, the grafts weren't taking, or they were growing into some small tumors, and so we've kind of solved that issue. That doesn't seem to be a problem that we're running into at this point. But the questions I think we're still trying to answer in terms of stem cell is, when we graft a stem cell into the brain, we see this reinnervation. So basically growing new neurons in the brain that are trying to, with the hope of improving symptoms. The degree to which reinnervation occurs doesn't necessarily, or hasn't necessarily, correlated with improvement in symptoms. And so that's kind of been a little bit of a curious finding, where, we would expect when there's better growth that we'd have better symptoms, and that's not necessarily the case. And so that's one of the big one. And the other big one that we have to get there is that a lot of people have developed really significant and severe dyskinesias after implantation of stem cells, who have done so as a part of a research protocol. And so it's still, it still has a lot of excitement. I think that's still very promising. I think that we still are, it's still in the pipeline. And so we're, not something that we're going to see in the next year or two, but, maybe, 5 or 10. Let's see.
I think we will take one more question. Does PD medication have an acknowledged effect on vision or eye movement?
So depends. Some of them can, and so things like Artane or Amantadine can cause some blurred vision. In Parkinson's itself, the reduction in blink rate can cause some dry eye and some blurred vision, as well as part of Parkinson's disease itself, can cause some difficulty with looking at things close to the face and can cause some double vision, a phenomenon that we call convergence insufficiency. So it could be medication, it could be the Parkinson's disease itself, or it could be something else entirely.
Okay, thank you. There's quite a few more questions, and I know that Dr. Kuhlman's going to get back to seeing patients. So we will send out an email. I will send is it okay if I send you these questions and then you can answer them when you've got some time, and we'll send an email out to everyone who participated today?
Sure, I'd be happy to.
Pardon me?
Yeah, I'd be happy to do that.
Okay. All right, we will do that. Dr. Kuhlman, thank you so much. Thank you, everyone, for joining us today. We'll get you the answers to these questions. I will email them out. And we also have exercise tonight at 6 p.m. with Amy York, who is a physical therapist from University of Michigan. It's Power Moves, and it's on the exercise link, 6 o'clock tonight. Okay, we're going to leave. Thank you all.
All right, thanks everybody.
Thank you, Dr.